Hello, my name is Ann O'Day, and I'm a breast medical oncologist at the University of Kansas Cancer Center. And I have the pleasure today of moderating our panel about metastatic breast cancer and cardiotoxicity. And I'm joined by two lovely ladies, Janie Metsker, who is a nurse navigator at the St. Luke's Health System, and Lori Ranallo, who is a advanced practice provider in the KU Breast Cancer Survivorship Program. So we're going to jump right in today with a case. This is a 44-year-old woman who was diagnosed with invasive ductal carcinoma. This was a high-grade and HER2-positive cancer. She underwent neoadjuvant chemotherapy followed by surgery with curative intent. And unfortunately, she developed a recurrence in both the lung and the bones approximately 5.5 years after starting her initial systemic treatment for breast cancer. She really had no substantial past medical or family history. Her treatment for metastatic breast cancer consisted of trastuzumab plus chemotherapy based on the Cleopatra regimen. She received 25 cycles of trastuzumab in total before administration of pertuzumab and trastuzumab. After 13 cycles of pertuzumab and trastuzumab, follow-up echocardiogram revealed a marked decrease in her left ventricular ejection fraction down to 45%. She had no symptoms suggestive of left ventricular dysfunction. Since her metastases were found to have progressed at the same time, her treatment was subsequently changed to another anti-HER2 agent, TDM1, which is the sort of standard line, second line therapy. No medication was given at that time for the drop or decrease in her left ventricular function. Despite the switch of systemic therapies, her disease further progressed, and unfortunately, she succumbed to her disease 4 months later. So this case, I think, really highlights for us opportunities where cardiac oncology can really make a meaningful impact and difference for patients in terms not only of their survival, but certainly in terms of quality of life. And I just wanted to pose a question to my panelists. Janie, when you are working on supporting these patients as they go through kind of their journey with metastatic breast cancer, how do you make sure to really ascertain their cardiac risk factors or their baseline risk for cardiac disease? How do you identify those patients you think might be at the highest risk of having a complication?
Well, I think it's a lot of listening. I think it's getting those those pieces of information that may be seemingly very small and insignificant, but you kind of put those pieces together. And it's, I think a very important thing to engage patients in that education process, that they know which drugs, have that potential for cardiac toxicity, and, and how this will be monitored. It kind of provides a little bit of the motivation maybe for them through knowledge of why they need to go to that echocardiogram, why they need to get the EKG, and really, the safety, some, for their optimal outcomes, avoiding preventable suffering. Those are all the reasons why we do it. And I think the more we engage patients in that and partner with them in their own care, it really motivates them to follow through on these things. And then, really teaching them to, for me, it's teaching them about the side effects, because we know that, there are so many phone calls that you get each day as a clinician, as a provider, working with patients. And those very small, subtle differences, we want patients to report those. We want them, telling us that, maybe it's sudden, severe fatigue or shortness of breath, some of those things, difficulty lying flat. I think we're going to talk about some more of those things, some edema, weight gain, some sudden weight gain or a cough. I mean, there's just all those things that if patients are aware of those and I teach them about that, then they're really willing, and that opens that door too, as a clinician, for that patient to know that they should call.
Absolutely. Those are all great points. Sort of just highlighting the importance of really, making sure the patient is informed. And then, that way, as you said, if they understand the importance of that repeat echocardiogram, for example, they're much more likely to make it to that appointment, right? And to follow through on the results. Lori, from an advanced practice provider perspective, how do you approach your patients that you have, that you share in practice with the breast oncologist, and making sure that those patients, hit those benchmarks of making sure that 3-month or that 6-month echocardiogram is completed? And how do you see your role in that?
So we know that heart monitoring is so critical with these cardiotoxic potential drugs. And so we want to make sure that patients are scheduled for those visits prior to leaving the clinic, that we print out a calendar for them. And, in addition to that, I think it's really important in this case specifically, the patient didn't have any symptoms of dysfunction. So it's really our job as providers to recognize that drop in ejection fraction and get them referred to the appropriate specialties so that we can continue their therapy while maintaining their heart function.
Absolutely. Okay. Thank you. Thank you both. I think this case, unfortunately, I think sometimes this happens all too often. I know personally, I've seen women that come to me, whether they move or, they establish care and maybe after a year potentially of cardiotoxic medication and haven't had assessment of their cardiac function for that entire year. And so by the time we're monitoring that and looking at that, they've already had this sort of cumulative toxicity. So I know that just can't be, overemphasized enough. So when we talk about cardiotoxicity, we know there have been tremendous advances in cancer treatments that have led to improved outcomes. And unfortunately, the trade-off in that sometimes is increased cardiotoxicity. So it puts more responsibility on us as the multidisciplinary breast cancer team to manage the acute and long-term issues for cancer survivors. There have been multiple position statements in terms of how to monitor cardiovascular toxicity. The European paper here, the one that we tend to use more in our clinic is from the Journal of Clinical Oncology here, entitled Prevention and Monitoring of Cardiac Dysfunction in Survivors of Adult Cancers. These are the ASCO clinical practice guidelines, the most updated ASCO guidelines. And so those really serve as the basis of our monitoring program. We know that there are this ever exploding list of therapeutic interventions which can lead to cardiac toxicity. We've given you this today just because we want you to have a comprehensive list of resources. Not that we want anyone to sort of memorize this, but just to understand, when you look at some of the common, for example, breast cancer agents, you see there right at the top, the anthracycline chemotherapies, doxorubicin, epirubicin, for example, and the incidence in terms of percentage of heart failure and impact on the heart. What we are learning is that sometimes, it's not just the impact on left ventricular function, but we're seeing more and more now some of these targeted agents have an impact, for example, on heart rhythm and require more careful cardiac monitoring in terms of EKG rather than echocardiogram. So this is an sort of ever evolving area that we will continue to, expand our fund of knowledge. We know the cardiovascular events due to cancer treatment sort of here gives us kind of a flow sheet of, the different areas that can be affected. Certainly the vascular system, metabolic system in terms of some of these drugs causing dyslipidemia or hyperlipidemia or elevation of triglycerides, which ultimately downstream lead to cardiac toxicity. Some of these medications can lead to, as I mentioned, EKG abnormalities, specifically QT prolongation is something that we see quite a bit. Some of these medications increase the risk for thrombotic disease or hypertension. So these are all ways in which our anti-cancer medications can increase the risk for our patients. So kind of just when we think about the breakdown here in terms of how we kind of look at the different sort of buckets of risk factors for cardiotoxicity, we start out with their previous cardiovascular disease. So that, to me, that's sort of the low-hanging fruit. If you take a patient that has known coronary disease or known valvular replacement, something along those lines, we know that that's going to be a person that's going to be at very high risk. Then we look at their previous treatment. Previous cardiotoxic treatment, specifically anthracyclines, the radiation therapy to the chest wall or to the left chest particularly. Then we look at their lifestyle risk factors. So depending on whether the patient has been or is a current smoker, if they are or have been for many years overweight, those are all things that could impact their cardiac risk. And then of course the things that they can't control, things like their age, things like their family history, all things that are not within their ability to control, but all impact their risk for cardiac dysfunction. So the things that we look at here, prior anthracyclines, obviously we've talked about that. Elderly patients, those over 75 are at particular risk. Prior mediastinal or chest radiotherapy, smoking, hypertension, and even patients that are exposed to cancer medications or radiation therapies at a very young age, under the age of 10. We know the combination of trastuzumab and an anthracycline can be particularly toxic. So those are patients we watch out for very carefully. Elevated biomarkers before initiation of anti-cancer therapy. So people who maybe have had elevated troponins, elevated BMPs, kind of before we even start our therapy. Baseline abnormal systolic function. So when we measure those patients at baseline and we see an ejection fraction below 50%, we know that those patients are at particularly high risk. And then of course, pre-existing diabetes. The common definition of cardiotoxicity is going to be an ejection fraction either below 50% or a decrease, an absolute decrease by 10% or more from the baseline value. So this is important for us to understand because we can have a patient that starts out with an ejection fraction of 65%, for example, drops to 55% and is still classified as, quote, normal, right? But we know from lots of clinical trials that patients that have a 10% or greater drop in their left ventricular ejection fraction are going to be at risk for long-term sequelae of that particular therapy. The symptoms, as you all know, things like shortness of breath, lower extremity edema, dyspnea, swollen or tenderness of the abdomen, and unexplained cough sometimes might be the only presenting sign of a drop in cardiac function. It's important for us to understand that if we look at overall in cardiovascular disease mortality in women both with and without breast cancer, and you see here the women with breast cancer denoted by that dotted line, you can see there that overall mortality obviously is higher in women with breast cancer. But if you look to the right of your screen in terms of cardiovascular mortality, when you look at, about 7 years from the diagnosis of breast cancer, so 7 years into their journey, between about 7 and 10 years, you start to see the women with breast cancer having much greater incidence of cardiovascular mortality compared to women who have not been diagnosed with breast cancer. So we know that oftentimes our oncologic studies have endpoints of potentially, sometimes 5 years, sometimes 7 years of follow-up. And so often what's missing in that literature is what happens to these women after their treatment. We have many patients who are long-term survivors and long-term survivors living with metastatic breast cancer who have well passed that 7 or 10 year mark. And we know that those women are at higher risk for cardiovascular mortality. And so we have to do everything we can to intervene for those patients. As you all know, there are many tests which are here for us to help aid us in sort of screening these women and diagnosing them. Echocardiogram, of course, we're all aware of. MUGA, the nuclear medicine test. Cardiac MRI is something that's really coming into becoming increasingly common. And it's very accurate and reproducible and detects diffuse myocardial fibrosis, but not yet is it widely available. Also for our women that are claustrophobic, that can be really challenging. In terms of blood tests and biomarkers, so things like troponin and BMP, these are accurate and reproducible. They're widely available. But the problem is we don't have a very expansive body of evidence to support their use or how to apply those. It's not really well established. But these are sort of the primary tools that we have to look at. We know that there are classes of cardiovascular therapeutics that have been shown to offer some sort of cardio protection, and we offer you this list here just so that you have this as a resource. In terms of clinical integration, steps of risk management associated with late and long-term effects of cancer, we want to make sure we gain a baseline understanding of risk. We sort of want to make sure we onboard patients with the appropriate needs assessment and then make sure we're educating patients on the risk and implications of ongoing care. That can be done through videos, handouts, lots of tips on lifestyle modification, healthy lifestyle, and so on. We want to make sure that we have this ongoing risk assessment. So just because we assess these women at baseline, that is just the very, very beginning of their journey oftentimes. So we want to make sure that we do that in an ongoing way. And then in terms of intervention, we need to make sure we engage our survivors. We need to make sure that we're having appropriate referrals to specialists in the field of cardiac oncology and offering support for these women. At this point, I am going to turn it over to Janie, and she's going to talk to us a little bit more about what she sees in her collaboration with her patients.
So thank you so much, Dr. O'Day. And, I thought one thing that might be helpful is just to kind of talk about, since we're talking about metastatic breast cancer or MBC, it really is a subset of patients within breast cancer that have a very different journey. And so I wanted to highlight just the fact it's important to understand the difference when you're dealing with these patients, that, it's very much different than an early stage breast cancer patient, which gets has a very defined time frame for their treatment. Yes, it's a very vulnerable and chaotic time for all breast cancer patients when they're diagnosed. But ultimately, the earlier stage breast cancer patients have a more predictable course. They're going to have a start and at least approximate end date. Then they move on to that survivorship phase. They may, they usually will get some type of a survivorship care plan from a provider. And it's just a very different journey with MBC. It's much more obviously ongoing. It's more unpredictable. Many women describe this as a roller coaster. The care plans, they don't normally get a regular, what we call survivorship care plan. And they don't really, I will tell you, I have talked with a lot of these women in our support groups and things, and they really don't see themselves as survivors. As much as we might want them to, they really don't. I think this is an excellent description of experiencing MBC. You think you're going to be flying to Chicago and land at O'Hare, and you end up on Mars. Very many, women did not see this coming. And it's just a very different experience for women going through metastatic breast cancer than the earlier stage breast cancers. I want to hit on this a little bit here because nearly half of all surveyed MBC patients report a sense of feeling like outcasts or isolated, especially, and this is just almost surprising, within the larger social context of the breast cancer community. This really cannot be overstated. What this does, because it can really cause a silencing effect. It can really result in isolation and even some secrecy. One of the things I think that's really interesting with this, because of the misinformation that's out there, we're getting more and more leverage with this in the general population, the education of the public of what MBC is, because there's sometimes patients feel there's a social rejection, some isolation, shame, self-blame. It's one of those things that, then sometimes they'll feel like their family and friends kind of are almost like blaming them. Well, and it comes out like this. Well, you must have done blank. You must have not breastfed your children. You must have, they have this blank of whatever they feel like maybe caused it. And I think it's just one of the things we try to do to make ourselves feel like, well, I'm probably protected from that. And so just some of those stigmas and myths are really very difficult for MBC patients to deal with. One patient, and I just love this, she kind of described herself as a chameleon and how she presents herself to family and friends. I've got my little chameleon over there to remind me about that. Because she says she feels like she's changing colors with how she feels and how she talks to people about her diagnosis. With some people, she can be really, she's very, very guarded, a little bit more guarded. And then with other people, she can be very open about everything that's going on. And really, she described a desire to blend in with people who don't know about her diagnosis so that they'll treat her as they do everyone else.
Wow. That's really impactful. And it's really unfortunate to hear that you're hearing these stories from women who feel this sort of self-blame. We often think, when when you look around in October and you see all the support in the pink and the everything, you would assume that these women sort of feel lifted up, but what you're reporting is that they're actually feeling that they're not included in that sort of rally, right? That it's really more for the patients that have kind of crossed the finish line, if you will.
Right, they do. They feel like they're sort of I've had them tell me, I feel like I'm a failure of the pink ribbon program. And, you know, they don't, a lot of them, you know, there's some that will have their pink boa or their pink shirt and all, but a lot of them are like, I don't care to wear any pink, you know? And so I think that there's just a real mindfulness about that in really how we approach it, even on our clinics, and how we are, you know, what we're promoting to patients because of those, you know, those feelings. You know, we talked a little bit about some of the fears and things that people had. You know, having any kind of cancer treatment can be certainly very, very fearful, but cancer treatment can be very, you know, with, there we go. The cardiotoxicity fear, and I don't want to overstate this, but, you know, there are sometimes that women are more afraid of the cardiotoxic effect of a drug. They learn that it has that, and they're more focused on that than they, in some ways, than they are the cancer. And I think the nursing consideration for me there is just to understand and recognize that fear and maybe the reason for the fear. Sometimes there's some underlying, you know, psychological comorbidities, or the patient's heard these negative stories out there about somebody who had heart failure because of something. And, you know, so there is that it can be a very real fear that can impact their follow through with treatment. Next slide. Some of the nursing considerations when you really think about MBC, we know that, you know, women are surviving longer with it. There's so many new therapies out there today that it's really almost more of a chronic disease. And I know, Dr. O'Day, I'm sure you're seeing this in your practice as well. There's, you know, many, many lines of therapy that these women have. And so this knowledge, you know, of these newer treatments is so important for, as nurses, to have, you know, that knowledge of what the treatments are, the cardiac monitoring that they may be partnering with you, Lori, on getting those things ordered and making sure patients are following through, of all these different medications that are available, the CDK4/6 inhibitors, the targeted therapies, immunotherapies, and some of those, you know, just that knowledge, a good knowledge of the patient's history, and those, which we talked about earlier, the signs and symptoms of cardiac function. I love this slide because you solemnly swear to follow my advice. You know, it's like you swear on a stack of Bibles or something. And this area of patient engagement. And I really wanted to talk about this because I think it is so impactful, and it can jeopardize patient outcomes when patients are not engaged, and it makes our jobs so difficult and often frustrating. And, you know, so really, what is patient engagement? Just very quickly: knowledge, skill, competence to manage their healthcare, be involved in healthcare, act on information. You know, high engagement. We know what that patient looks like. This is the patient that's, you know, calling you. They want to have all their appointments down. They want everything before they leave. They're going to follow through on every instruction you give. Then you've got those low engaged patients that, you know, that honestly, you know, they either don't understand, or they're very unmotivated, or they don't have the resources. And that's so much where nurse navigators come in, your social workers, financial navigators, all those people that can help the patient develop those, you know, the confidence and some of the abilities, and maybe set some goals. Those are some of the things that sometimes you have to get to. Well, why aren't they coming? Is it really truly transportation, or is it really the fact that, you know, that they, you know, have their grandchildren, or, you know, other reasons that they don't want to come, can be those, you know, those underlying factors that we don't always take into consideration. So this, you know, really patient engagement, I'm going over that really quickly because, you know, it's one of those things that it's kind of a buzzword, right? You know, in healthcare, and, you know, it's how do you develop, you know, the interventions to help patients, and that formalized process can be pretty cumbersome. But I think on just a day-to-day basis, we do this all the time. We are helping the patient, we're strategizing with them how to be in partnership with them, and how to make that treatment successful, so that you don't have that patient where we've seen a patient that literally had to do the loading dose of Herceptin every time because she missed so many appointments. And so it was really trying to come up with ways and help her set some goals and how to be more successful in that, so that she was getting the treatment and hopefully getting a better outcome. The next one is about just a little bit more about this in a little more detailed fashion of patient engagement and advocacy. And I think how this works together. And really the question becomes, why does it matter? You know, it informs us how to be in partnership with the patient and really their family. And, you know, MBC is a family affair. You know, people are very involved with their loved ones. The patients are very knowledgeable. They know their treatments. They know the medications. Many of them are very, you know, very aware of all that. You know, it's going to be ongoing treatment, as we said earlier, but also the treatment regimens are really complex often. And so it's very important to, you know, kind of recognize why this matters and how we partner with patients so that we do have that compliance with treatment, so that there is, you know, we give safe care, we have better outcomes, we avoid that preventable, you know, suffering. And then I think the really important thing I want to focus on is goals, because I think this becomes a very big area with MBC, especially. You know, patients don't want to disappoint their family or friends, or for that matter, their doctor. And, you know, it's very important for patients, for us as providers and nurses and physicians and whoever's involved with that patient, to know what the patient's goals are. Are they wanting to try to continue to work? Is it a lawyer who has a thriving practice and she's a partner? Is it, you know, is it, do they have that trip to Europe planned? They've been planning it for 10 years and it's, you know, finally on the radar and they want to go on that? Or do they have a child getting married? Is that, you know, an upcoming wedding that's months away and you're, you know, concerned about, you know, how are they going to be doing by that time? The birth of maybe a child, a grandbaby or something. So to know what those goals are and what does the patient want to continue to do? Do they want to be able to garden? Do they jog? Do they do CrossFit? You know, those things that we can help them really maintain their quality of life and then restore quality of life. So knowing those goals is really important in the treatment plans, and especially with you know, with metastatic breast cancer patients. You know, I think it sometimes means having that hard conversation. Maybe with the patient, you know, initially, or helping the patient have that difficult conversation with their, you know, support person, their spouse, their daughter, their whoever is supporting them. And, you know, sometimes it's also helping the patient and really helping them to understand how to have that conversation with their doctor, because, you know, there's so many options and treatment lines that may be available to a patient yet, and we want them to continue as long as they can and as long as it's reasonable. But it can be a very difficult conversation because patients don't want to let their doctor down either. After having some end-of-life discussions with a patient recently, she says, well, I have this little app on my phone and it's a fireplace. And I'm going to pull it up at my next appointment and say, let's have a fireside chat. And I thought that was a really great, you know, a great point for her, and empowered her to come up with her own way to communicate some of those things, you know, to her doctor and also to her family and friends. Mm-hmm. So, you know, I think that's, you know, really the important, you know, points here. They, you know, the little car there, this one patient described to me that she sees herself as the driver. And, you know, I thought, you know, really to be an advocate for our patients and engage them in their own care and share decisions that we're making together, really it's our job to clear that road for them so that they can, you know, keep driving as long as possible, achieve their goals and complex, you know, treatment decisions, end of life decisions, and all those things that really go along with this. So those are my thoughts. And you know, Dr. O'Day, any, you know, closing thoughts or?
I so appreciate your insight, Janie, and I love the way that you explained this. And every time I listen to you talk, I feel like I will go back to clinic the next day and be a better doctor and try to just do the best I can to create that two-way communication and empower the patients to have that communication as well. And some of what you said reminds me of something that I try to remind my patients, that we want to make sure that we're designing our treatment for metastatic breast cancer around their life, right? And not their life around the treatment. And I know sometimes it doesn't feel that way to them, but we want to make sure that they understand that in the big picture, that's our goal. And so we absolutely want to make sure they feel really good for those important weddings or baptism of a grandchild, or, you know, whatever it is, as you said, that's important to them. So I really appreciate your points. We're just going to end off with a case. This is a patient of mine, a 53-year-old postmenopausal woman. She was originally diagnosed with breast cancer at the age of 39. She had a large right breast mass that ended up biopsy showing an invasive ductal carcinoma, which was hormone receptor positive and HER2 positive. She unfortunately was diagnosed with metastatic breast cancer to the liver at diagnosis in 2006. She had neoadjuvant chemotherapy, as you can see here, anthracycline-based with epirubicin, in addition to the Herceptin or trastuzumab. She had a bilateral mastectomy in 2007. At that point, really having a very good response. But unfortunately, her PET scan demonstrated in August of 2007, she had persistent liver metastasis. Unfortunately, in October of 2007, she had a drop in her ejection fraction down to 40%. At that time, her Herceptin or trastuzumab was held. She was referred to Cardio-Oncology. She was placed on Coreg and lisinopril, and her Herceptin was able to be restarted. From 2007 to 2014, she was maintained on Herceptin, had another slight drop in her ejection fraction from 55 to 50% in 2012, at which time her treatment was switched around a little bit. And you can see there that she continues on treatment even today. Her most recent echocardiogram is 58%. This is a patient that we're trying to get ready for her daughter's wedding in September. So again, we're trying to make sure that she feels really good for that great event in her life. But this is, to me, highlights a perfect example of a patient that you know, with the appropriate sort of screening for cardiac monitoring, the appropriate intervention and preventative medications, can really go on to benefit from all of the new therapeutic interventions which are now available for these women. But our job, again, really is to make sure that we do our best to intervene. We recognize the risk factors, we intervene appropriately so that these patients can have the longest life and the best quality of life possible. So with that, I want to thank you all for your engagement today. It went by so quickly. Thank you for this time. Thank you for your insight. And that will do it for us right now. Thank you.